Hello students! Welcome to the 6th video lecture for Healthcare Ethics, Fall 2020. Our topic this week is the principle of justice. This is the last topic that we will cover before the midterm exam. After this week, you will have a week to study for the exam. And that means there will be no worksheet next week and no video lecture. Instead, next Sunday, you will receive an exam review guide. Okay, so this is the last lecture before the exam. The exam is a take-home exam. We will discuss the details of the exam this Thursday in our weekly Q&A session, so I strongly recommend you attend this week, even if you haven't been coming for the past couple weeks. You will receive the exam next Thursday, October 15th at 6:00 p.m. And then you will have until the end of the day, that means 11:59 p.m. on Friday, to complete the exam. So you have a whole day and a little bit more to finish. Okay, so our topic this week is justice. And our reading was a chapter from a textbook called Practical Ethics for General Practice, which was written by Wendy Rogers and Annette Braunack-Mayer and published by Oxford University Press in 2008. The title of the chapter that we read is Justice and Resource Allocation in General Practice. So, there are a few important things to note before we get into the reading. Remember that all texts are written for an audience. Even the worksheets that you guys write, right? They're written for an audience of one, me. So based upon the publication information, what can you infer about the audience of this chapter? So first of all, it's written for a British or UK audience. So not an American audience. You can tell this by the publisher. It's published by Oxford University Press. And you also might have noticed from some of the vocabulary in the chapter, words like GP and surgery. And you might have noticed as well from the focus of the article, they talk a lot about socialized medicine, which is not a feature of the US medical system. Okay, so it's written for a UK audience. What else can you notice? Well, the title is Practical Ethics for General Practice. So it's written for general practice. That means that it's an ethics textbook for physicians who are working in general practice. What does that mean, general practice? So general practice is the British version of primary care or family medicine. So there's, they use the abbreviation GP a lot, which stands for general practitioner. We would say PCP for primary care provider. They also use the word surgery a bit later, but they don't mean operation. A surgery in England is a doctor's office. So instead of going to visit the doctor's office, you go to visit the doctor's surgery. I know it's weird, but it's just a detail that you guys need to know in order to figure out this reading. Okay, so also a note on the form of this article. It is a textbook chapter. So that means, unlike some of the other readings that we read, which were articles, it doesn't really have an argument that it's trying to make, though sometimes it does. And it also has these helpful little boxes, right? It's there to help you learn things, and it puts the things it really wants you to focus on in these lovely little blue-green boxes, right? So pay attention to those boxes. So there are 3 kinds of justice that we are going to discuss in this class. 2 of them show up in this article. So the kinds of justice that we're going to talk about are distributive justice, procedural justice, and social justice. This reading focuses on distributive justice, and it discusses procedural justice a little bit. It hints at social justice, but it doesn't really talk too much about it. Social justice is something that actually comes from outside the traditional framework of healthcare ethics. It comes from a tradition that is called critical theory in the humanities, which is born out of a different philosophical tradition than healthcare ethics. So we will be addressing this concept of social justice using some different kinds of readings in the second half of the course. All right, so what do these three terms mean? Distributive justice, procedural justice, and social justice. So I'm going to answer it with some questions. So this would be a good thing to take down in your notes. So the question behind distributive justice is, does everyone get a fair share? Are the goods of the society distributed equally? Procedural justice is about procedures. Are the rules fair? Okay. And social justice, we can think of as a question about society. So, as its name implies, so do the lived conditions of society reflect the moral ideals of that society? So I'm going to run down those questions again because they're important and they're the sort of big governing frameworks for this class, or for the way we're dealing with justice in this class. So the question behind distributive justice is, does everyone get a fair share? The question behind procedural justice is, are the rules fair? And the question behind social justice is, do the lived conditions of a society reflect the moral ideals of that society? Okay. So you will note that the first two, which show up in this article, distributive justice and procedural justice, in terms of healthcare ethics, both of these terms assume a scarcity of resources. So the authors, Rogers and Braunack-Mayer, on page 4 of the article, they write, referring to their case studies, what all these situations have in common is that there is not enough money, time, staff, machines, or other resources available to do everything for every patient. So the authors tell us that there just isn't enough money for everyone to have all of the healthcare all of the time. But is this really the case? They contend quite strongly, below that quote I just read on page 4, scarcity is thus an inevitable characteristic of any health system. But I want you guys to remember that health systems are created by people, as is money, which means that we can create them any way we want, right? And we have created them so that there is scarcity. Even though I am asking you to trust these authors, because they do really know what they're talking about, you should also understand that they are a part of a larger system that determines what they can and cannot say, that determines that healthcare always functions in a system of scarcity. So I'm asking you guys to read critically and be skeptical of claims to inevitability. So when they say scarcity is thus an inevitable characteristic of any health system, put your critical thinking cap on and don't accept the world as given, okay? So, you know, this is about thinking in terms of social justice and how the world might reflect moral ideals. That said, this article is about the world as it is. So they're not trying to change the world, they're just trying to manage within it. And their concern is how to distribute scarce resources equitably. Resources like money, time, medications, even organs for transplant, or access to high technology, fancy equipment. So distributive justice is about resource allocation, the distribution of scarce resources. I would write that down, it's a good definition. The most important thing that this article does is establish 4 criteria for resource allocation. And these criteria are need, capacity to benefit, merit, and rights. So I will return to each of these 4 criteria later in the lecture, but I want to flag them for you guys because they are the most important points in this essay. Before we get there, the authors tell us about 3 different levels of resource distribution. So the 3 levels of resource distribution, not as important to know, but kind of nice, and I'll tell you about them. So they are macro allocation, mesoallocation, and microallocation. So an example of macro allocation would be the Affordable Care Act. We can think also about macro allocation as the appropriation of government funding to search for a COVID-19 vaccine. So macro allocation is about distribution of resources on a really big scale, governmental scales, the WHO, the big things about budgets and projects that are way bigger than an ordinary hospital or healthcare provider. The second level that they talk about is mesoallocation. And this one is about the sort of mid-level. That's what meso means. Macro means big, meso means middle, micro means small. So mesoallocation is about things that happen on a sort of institutional scale. So hiring decisions at a hospital, say Montefiore Hospital in the Bronx, when they make a decision to hire more nurse practitioners, that would be an example of mesoallocation. They're deciding they have a certain amount of budget. We're going to hire these people rather than these people. Maybe even better, you could think about hospital negotiations with the nursing union. The hospital and the union have different priorities about how funds should be distributed in the hospital. So here again, mesoallocation and macroallocation, a lot of it is about budgets. Okay, so it sounds kind of weirdly like accounting, but it's like the ethics of healthcare accounting. Okay, this article focuses on the last one, which is microallocation. And microallocation appears in the opening little case studies as time management. So microallocation is about the allocation of resources on a small scale in a particular relationship between a healthcare provider and a patient. So in the example cases at the beginning, the first 2 are examples of physicians thinking about how to best distribute their time so that they can see all the patients on their schedule, but also address the needs of each patient. So time is the resource that gets distributed here. Okay, so microallocation is small scale interactions between the healthcare provider and the patient. Okay, so now you've got those 3 levels, you can forget about them. They're not super important, but it's good to think about how justice doesn't always function in one place. There are lots of ways in which we can understand justice functioning within the system of healthcare. Okay, so if beneficence, as we have studied, is a duty to do good, and non-maleficence is a duty to do no harm, justice, as an ethical principle, imparts a duty to steward resources. So the general assumption here is one of rationing. Think back to what I was saying earlier about scarcity. The authors of this article explicitly discuss rationing on pages 5 through 7, and there's a nice quote on page 7 in the discussion of rationing that helps connect this idea of distributive justice. So the duty to steward resources, steward means to take care of, to manage well. So the duty to do a good job making sure the resources get distributed. There's this nice quote on page 7 that connects that to one of our other key terms, fiduciary. Okay, so I'm going to read you the quote. This is actually Rogers and Braunack-Mayer quoting another author here. So, and you can tell that because it's offset on the page. It's a block quote. So they write, It is as though there is an unspoken social contract. Society has entrusted the clinicians the responsibility for taking the ultimate decisions about the allocation of scarce resources, and in return, society has absolved the clinicians from explicit democratic accountability for their stewardship of that responsibility. So the unspoken social contract here is a bit like a fiduciary relationship. So instead of the relationship between the doctor and the patient, which we have talked about before, this is a version of a fiduciary relationship that is between healthcare providers and the society writ large. Okay, so it's another way of thinking about how trust is established in the system of healthcare. You guys might also note those little quotation marks around society. Why are they there? It seems a little strange. Society has entrusted the clinicians the responsibility for taking the ultimate decisions about the allocation of scarce resources, and in return, society has absolved the clinicians from explicit democratic accountability. So you might note that this author, the little scare quotes tell you, is actually a little bit skeptical about this. The author is not really in favor of this unspoken social contract that they're talking about. And that's why those like little scare quotes mean, I'm not really saying this, right? That's one of the uses of quotation marks, and that's what they're doing there. That's why they're putting society aside. As they're like, society is this big abstraction that like maybe doesn't add up to what we think it does. Okay, anyways, the key thing for us to take away from this is that we can think about the fiduciary relationship as something that exists between society and healthcare providers, as well as between a healthcare provider and a patient. Okay, so then, what is justice? Let's get back to our key topic. If you guys turn to page 8 of the article, this is where the important part begins. I'm going to read you a quote. It's a fairly long quote, but it's an important one when you guys are trying to come up with definitions of justice later on. Okay? So, at its most simple, our authors tell us, at its most simple, justice is done when each person gets his or her due. This suggests that people who are equal with respect to their dues ought to get the same amount. Indeed, all theories of justice from Aristotle onwards have had as a minimum formal requirement that equals shall be treated equally and unequals equally. It's unequally. Okay, so the key part of this is that last phrase. There's a minimum formal requirement in all theories of justice, according to our authors, that equals shall be treated equally and unequals unequally. So what does this mean? Can you think of an example of equals being treated equally? Perhaps all dogs go to heaven? How about unequals being treated unequally? Like bad dogs should be punished, but good dogs should be petted? But the problem is, how do you know which dogs are bad and which dogs are good? That's what the unequals are. The good dogs and the bad dogs, they aren't equal, but how do you know? So this idea of treating equals equally and unequals unequally is a nice abstract rule, but once you start applying it, things get tricky. So this rule is, quote, a formal principle of justice, because it provides no detail about the circumstances under which equals should be treated equally, and because it does not tell us whether two or more people are in fact equal. So it is a formal principle of justice, and that means it doesn't give us enough details to apply it. So formal here, the root word of formal is form. So formal doesn't mean like I am formally dressed, but it means something like a blank form. So like when you get your form for your mail-in ballots, it is a blank form, right? And you fill it out, you supply the content. So it is formal because it is empty of content. Also note the role of equality here. So one of the key things in this formal principle, this formal rule, is establishing equality. And that's going to come back once we start talking about social justice later in the term. Okay, so before we answer the question of how you fill in this form, how you get the details of this formal rule, we're going to talk a little bit about how you make good forms, how you create fair rules. So that's what procedural justice is. You can think of it as making a good form that you're going to fill in with the contents of the patients. So the question of procedural justice, as I said at the beginning, is how do you create fair rules? And they suggest this sort of thought experiment that they get from a guy named John Rawls. So the thought experiment is called the Veil of Ignorance. And it's about imagining how to make a system with completely fair rules. So I'm going to read you a quote from page 8. Rawls asks us to imagine that we are in the hypothetical situation of deciding how to allocate a range of primary social goods, such as education and healthcare, in a society. He gives us total knowledge of the society that we are making decisions for, but we have absolutely no knowledge of what our personal position will be in that society. So the idea here is that if we know everything that there is to know about the society, except what our role is, if we have no personal interest in this society, then we can make a completely fair set of rules. So this idea of total knowledge that shows up in the Rawls thought experiment comes from a guy named Buckminster Fuller, whose world game is a way cooler version of this idea. So I suggest you Google it. Just Google Buckminster Fuller world game. And while you're at it, Google geodesic dome. Okay. But, and that means that it comes from a certain thought tradition. It's really embedded in sort of the idea of technocratic knowledge and sort of mid-century cybernetic thought. But back to the Rawls, you guys might also note that the hypothetical thought experiment that he provides here, that our authors kind of quote and say, oh, this is a good idea. This is how we might make good rules. It's completely impossible. It's just, first of all, not possible to have access to total knowledge of society. How could you do that? Like, it's just like, unless you're omniscient, unless you're God, you cannot know everything that's going on in society, right? And the only people who possess any kind of knowledge that approximates something like total knowledge are the people in a position of privilege within a society. That's sort of how power works. That's how knowledge structures power. So there's no point in pretending that the position you occupy in society is unknown. The position of decision maker, the person who makes the rules, is de facto a position of power. So this is a basic fact about power. So another way of saying this is Rawls, in his thought experiment called the Veil of Ignorance, is trying to imagine a position outside of society. But in reality, you, as someone who might make a system of rules, are always in society. There's no getting out of it, okay? So this thought experiment is impossible, and I want you guys to know that with your critical reading hat. But, and actually what comes out of it for our authors is something kind of similar. So their key takeaway from this, they list some like nice criteria for establishing fair rules that they get from another author, but their key takeaway from this concept of procedural justice is that they think that fair procedures do not necessarily mean fair outcomes. So even if you make the perfect set of rules, in the understanding of our authors, and I would agree with them on this, even if you make the perfect set of rules, once you start filling in the form, it's always going to break down. It doesn't guarantee fair outcomes. So procedural justice alone cannot establish a fair system. Okay. So they say this explicitly on page 9. They write, generally, fair procedures in healthcare will not guarantee fair outcomes, but they will help. So it is good to have fair rules, but it's not everything. We need this other concept of distributive justice. And distributive justice for them is explained by these 4 material principles that I outlined for you at the beginning. So a material principle of justice, as they name it, they set it up in contrast to the formal principles. Okay, so formal principles, think of empty frames, blank forms. The formal principles of justice that we encountered earlier are set up in contrast to the material principles of justice. So these are rules with stuff in them, with matter, content. They're not just these empty frames. And if a formal principle told us to treat equals equally and unequals unequally, but failed to tell us who was equal and who was unequal, so it failed to tell us which dog was a good dog and which dog was a bad dog, then the material principles, according to our authors, give us a range of standards that we may use to measure equality or inequality amongst people, right? So it's a range of standards for saying, this is a good dog and this is a bad dog. So unfortunately, it turns out that the material principles of justice, which are supposed to be like, I'm going to fill in all the content of this empty form, they are themselves somewhat abstract. Nonetheless, they are maybe closer to reality, to matter. So the 4 principles of distributive justice that they discuss are the allocation of health resources according to need, allocation according to capacity to benefit, allocation according to merit, and allocation according to rights. You guys should also note that there is no clear winner here. While the authors lean in favor of some of these over others, they are all viable options. They are all acceptable rules for distributing healthcare resources. If they weren't acceptable rules, the authors wouldn't have included them at all. Okay, so I'm going to take you through each of the principles in the order that they go through them. I'll encourage you to follow along in the reading, but also think about how these principles are different from each other, because that's what you're going to have to answer in your worksheet. And then once I get through all the principles, we will be done with the lecture. Okay, so the first principle they discuss is need. And on page 10, they give a pretty clear definition of it, which I will quote for you here. Need, a distribution of health resources according to need, means that, quote, people who are sick get treated and the sickest get treated first. Seems pretty straightforward, right? And in fact, they say that this is one of the sort of foundational principles of medical ethics. People who are sick need to get treated and the sickest need to get treated first. But it becomes kind of tricky once you try to figure out what exactly is a need. Who needs to get treated? And what is the distinction between need and want? So rather than thinking about like high stakes trauma situations, they want you to think about sort of low stakes, primary care office visit situations. So thinking back to the case studies at the beginning of their article, the case of Mr. Cervantes and Dr. Carter is a good example for thinking about this. It's a slightly better example than that weird case about Simone who wants cosmetic surgery on her nose. That seems like pretty clear to us that it maybe isn't a need, but like they want to kind of make it into a need. I don't really care about that one. But the case of Mr. Cervantes, who's really needy, he wants a lot of attention from the doctor, and he wants the doctor to explain everything really, really, really clearly, which is actually something we've talked about in this course, right? How it's the duty of the healthcare provider to explain the important, like the information that a patient needs regarding their health status and benefits and risks and all that good stuff, right? So this patient really, really wants all that information, right? But the doctor knows that if he spends an hour and a half with Mr. Cervantes, then he's going to be running late for the rest of the day, and all of his other patients who might have like more urgent healthcare concerns, who might be a lot sicker than Mr. Cervantes, all of his other patients are going to get the short stick. So Mr. Cervantes is a really needy patient, but does he really need the doctor's attention, or does he just want it? It's kind of tricky. We think that he's entitled to it, but then again, other patients are also entitled to Dr. Carter's attention. So the question that this brings us to is, who decides what is a need and what is a want? So maybe Mr. Cervantes really needs all that information, or maybe he doesn't. So this gets us to the question of subjective versus objective needs. And you guys should note that this doesn't actually solve this problem, but it gives us a vocabulary for talking about it. So subjective needs are the needs that people define themselves as having. This is a quote from page 10. Subjective needs are the needs that people define themselves as having. Objective needs are defined by someone else. Often the person who defines the objective needs in the situation of healthcare is the healthcare provider. So they say the objective needs are often defined by specific categories of people who have the authority to make judgments about the severity of need. So you should know that subjective here does not mean fake, okay? It doesn't mean that it's not real. And objective doesn't mean that it's true. So it's an objective need, it's a real need. That's not quite what they mean here, right? These are sort of easy colloquial additions, but they don't apply. So you should sort of get them out of your head. Subjective just means that I, as a subject, have identified my need. I am a subject. Objective means that someone else, viewing me from the outside, someone who has the authority to view me as an object, has identified my need. So subjective is me as a subject. Objective is me as an object. Someone else from the outside saying, aha, you have this need. In the first example case, at the beginning of the article, the patient, Jennifer, who is, she's concerned about trying to conceive, but the doctor thinks she seems really sad, like maybe she needs to see a mental health counselor. She does not have a subjective need for mental health counseling because she doesn't say anything about it. She doesn't articulate her need, so it's not subjective. She might, on the other hand, have an objective need if Dr. Schroederer had stopped and talked with her and, say, diagnosed her with depression. That would be an objective need because he is looking at her from the outside and saying, aha, you have this specific mental health need. Okay, so subjective would be the patient self-identifying their need, and objective would be the healthcare provider identifying the patient's need. Needs, our authors claim on page 11, are not things that can exist outside of the resources that are available to meet them. They give a kind of confusing example for this. They talk about a woman in need of incontinence pads, but she can't get them because the funding structure for the delivery of free incontinence pads where she lives, right? But what they're trying to say here is that in healthcare, we understand needs in terms of available resources. So you can only need things that you can eventually get in this system. So it would make no sense for me to say, need insulin. If I was a diabetic and I needed insulin, it would make no sense for me to need insulin in 1905 before the discovery of insulin in 1930, okay? Because no one knew that insulin existed, so no one could, people knew that it existed, but they knew that there was something wrong with diabetics, but they didn't know about insulin, so you couldn't need it, right? So, or in a world where there was no such thing as COVID-19, it would make no sense for me to need a COVID-19 test, right? So needs can only exist in a situation where, in healthcare at least, in a situation where we understand that there are resources to meet them. So these two things, it seems like the resources are developed in response to the need, but in fact, the needs sometimes are developed in response to the resources. The idea is articulated a little bit more clearly in the next paragraph. So they talk about a case in which there is an unemployed man who is depressed on page 11. For example, depression in a young, unemployed male might be better dealt with by finding him a job than prescribing him antidepressants. So the question here is, should the provider prescribe antidepressants for this patient? He's clearly depressed, but the thing he needs is not really antidepressants, but a job, right? At least according to the details of the case that were given. So it seems like the provider should send him to a job counselor, but that's not really the kind of referral that a physician can make. So our authors write on page 11, if the real need cannot be met by the health system, should the health system meet the substitute need at all? So should the provider give this guy antidepressants if he can't refer him to a job counselor? It's a real question, right? And it's a good question for thinking about social justice. So the question, another way our authors articulate this on page 11 is, how do we decide which services are legitimately the responsibility of a health system and which services fall outside its reach? So you can think about this in terms of our current political discourse and the phrase that people have been saying a lot lately, which is racism is a pandemic. The idea behind racism is a pandemic is that racism is a public health crisis, just like COVID-19, and it's something that we might be able to respond to in the same way that we are responding to COVID-19. Another example of thinking about what things belong, what things are the responsibility of a healthcare system and what things are legitimately fall outside of a healthcare system's responsibility is the health commissioner, the former health commissioner of the city of Baltimore, Dr. Leana Wen. So a couple years ago, Dr. Wen declared gun violence in Baltimore to be a public health crisis. She argued that the city could and should use the tools of epidemiology to address a problem that had typically been addressed by a different system. So gun violence has traditionally been addressed by police, but Dr. Wen was saying it should be addressed by doctors. So she argued that doctors had the responsibility to address gun violence because it was a leading cause of death in the city. So you don't have to think if she's right or wrong, but you can see here how the question of what is the responsibility of a healthcare system is connected to concerns of social justice. You might even think about the environmental argument here. So when people say things like air pollution and carcinogens and climate change are health issues, and on some level they all are, right? The argument is that we can address them with the tools of healthcare, right? That these are health issues as well as political and economic ones. So the question of determining which services are legitimately the responsibility of a health system and which services fall outside its reach is a very tricky problem. Okay, so that was all under the principle of allocation according to need. Right? Even this big question that we sort of dallied into according to social justice. So all of these discourses are talking about the idea that we should distribute health resources according to need in the population, in the individual patient. Another way of thinking about how to distribute health resources is in terms of the patient's capacity to benefit. So this is the second of these 4 ways of distributing things that they talk about. And capacity to benefit is actually quite different than need. So the concern here is about the effectiveness of the treatment. So not does the patient need it, but will it work? So knowing that not every patient will benefit equally from all treatments, the question here is how much will this patient benefit from the treatment? So this is connected to some of the stuff you guys learned in terms of risks and benefits and informed consent, and it's also connected to this idea of quality of life. So don't worry about the QALY, Q-U-A-L-Y, abbreviation that they use, but the point of that is that they are trying to measure the patient's quality of life and length of life together. And it turns out that quality of life is really hard to measure. So, but quality of life is deeply connected to capacity to benefit. So if you benefit from a treatment, it might not only extend your life, but improve your quality of life. If you are confused by this abbreviation QALY, you can just substitute the words quality of life for it basically every time it appears. Our authors note that the QALY metric that they provide us is ableist. This is a good vocabulary word for you guys to know. It's not actually one that appears in their discussion, but it's the sort of condensed version of what they're saying. So ableist is a word like racist or sexist that refers to discrimination against disabled people. And the idea behind the QALY is that life is only worth living if you are in perfect health, whatever that means, right? And so it discriminates against people who are disabled, who by definition do not live in some kind of perfect health. But does it imply, so it implies this metric that lives not lived in perfect health are less worth living, right? That doesn't mean that we should throw out quality of life concerns altogether, but it just means that they're actually really tricky to define, and they are, in fact, qualitative. Qualitative means that it is about qualities. So you think of like a nice quality, I don't know, a nice quality shirt. Quality refers to things that are difficult to count, usually. Whereas quantity, quality is often contrasted with quantity. Quantity refers to things that are countable, right? So the quality metric is a way of trying to count things that are qualitative, which is very hard to do. And it turns out that they make some bad assumptions when they try to do it, okay? But that doesn't mean that we shouldn't be concerned about quality of life, and we shouldn't be concerned about how to distribute resources so that they might better improve patient quality of life, as well as patient length of life, right? But it does mean that it's really much harder to measure, even in contrast to something like need. So we might go even further in terms of the discussion that the quality is ableist, because it posits the idea of perfect health, right? We might go even further and ask, are any of us, are we ever really in perfect health? So the fantasy of perfect health is an ideal that is generated by the medical system, and it is an admirable ideal, one that we might want to strive for, but one that has little grounds in reality. Okay? So at any rate, that was all under the capacity to benefit. And you can think about the capacity to benefit as how should we distribute these scarce resources that we have of healthcare? Well, should we give them to the people who need them most? That would be need. Or should we give them to the people that they will help the most? The people who need them the most are not necessarily the same people who they will help the most, right? So someone who is really, really, really sick might not get better if they get the same treatment that someone who is a little bit less sick gets, right? And if you only have one treatment to give, you might decide to give it to the person who is a little bit less sick because they are more likely to recover with this same treatment, right? So the question here is, can you benefit from the resources at hand? We'll return to this when we get to the case of Jahai McMath later in the term. Okay, so that's capacity to benefit. Merit, the idea that you would distribute healthcare resources according to some sort of idea of individual or group merit. So they write on page 16 that, so desert here, I'm going to use the word desert in this quote. It means that you deserve it. It's a synonym for merit. So the idea of allocating resources according to desert, according to merit, makes sense only when people can do something to influence their desert, like training hard to win a prize at the end of a race on page 16. Okay, so the idea here is that you get healthcare because you deserve it, right? Just like the idea in our class is that you get your grade because you deserve it, because you have worked hard for it, right? Or you win the race because you have trained hard for it, right? Now there are some there are key critiques that we can levy at the idea of merit itself. But what's important for our understanding here is just that you see how it might work in healthcare, because it seems really kind of strange, right? You can't train to be a good patient the same way you can train to be a good runner, right? So the idea that people should get healthcare because they deserve it is kind of a weird one, right? We might, as a side note, say that this is essentially the criterion inherent in the capitalist model of health, because capitalism equates monetary worth with all other forms of worth. So the idea here would be, if you can buy it, you deserve it, right? So that's part of the reason that our authors who are working in a socialist healthcare system are a little bit skeptical of this idea of merit. And I think rightly so. But they offer us some sort of interesting ways of thinking about it that might sound very real, and bring it sort of down to the level of ordinary patient-provider interactions. So, from the perspective of the provider, the question might go something like this. Does this patient deserve my attention? Should I treat this nasty, racist, ungrateful patient who calls me all sorts of names and refuses to take their medication the same as I treat this other patient who is polite and kind, who does exactly as I recommend and is very grateful for my help, right? In theory, at least, you should treat them both the same. So we'll see an example of this kind of difficult relationship between a patient and a provider in a couple of weeks. But in theory, at least, you should treat both of these patients the same, but you can see why you wouldn't in practice, right? So our authors say on page 15, personal appeal ought to be morally unacceptable. But sometimes it turns out to be the reason we treat people differently. So they talk about appeal in terms of character, right? So that would be this, nasty, racist, ungrateful patient, right? That would be their character. And they also talk about personal appeal in terms of compliance. So that would be the part about them refusing to take their medication, right? And when we get into questions of compliance, it gets a little bit trickier, right? So a patient who refuses to take their medication versus a patient who takes their medication, it does as the provider recommends, who is compliant, that distinction might actually have some merit in the eyes of our authors, in terms of how you should distribute resources. Should you give, if there's a scarce amount of medications, should you give medications to the patient you know won't take them? Or should you give them to the patient that you know will? Seems pretty straightforward, right? So compliance, the idea that the patient will do as you say, is a part of character, but it is different than this idea of character, the idea that the patient is a nice person. Because it might actually influence other metrics like the effectiveness of the treatment, okay? Another way of thinking about distribution according to merit is in terms of social role. So they talk about 3 kinds of social role: past, present, and future, right? The idea is that you did something important in the past, you are someone who needs treatment importantly in the present, or someone who might go on to do great things in the future. In the United States, referring to this past social role, we think that veterans, unlike the rest of the population, veterans are entitled to medical care provided by the state as a reward for their past service. So this is an example of distribution according to merit. So we as a society value the social role that these people have played as soldiers, and so we have established the Veterans Administration hospital system. So veterans get healthcare distributed to them according to this concept of merit. You can also think about the social role idea in terms of recent discourse regarding healthcare workers and first responders for COVID-19. So the question here would be, should healthcare workers get priority in terms of access to treatment for COVID-19? Should people who are working on the front lines get priority? Should essential workers get priority in terms of access to treatment? Maybe, maybe not. What about access to testing? Also a healthcare resource that is currently quite scarce. So, in fact, in a lot of places, we are distributing the resource of testing, of diagnostic testing for COVID-19 according to this question of merit, right? And it's also kind of linked to capacity to benefit. Because you, as someone who is working in a situation where you are likely to get this COVID-19, are more likely to get a positive test result. So the test is more useful for you. Okay, so sorry, that was a slightly circuitous aside, but the important thing here is like thinking about is your status, is your role in society, that thing that John Rawls was trying to get us not to think about, is that role that you have in society something that should influence your access to healthcare? Okay, so Rogers and Braunack-Mayer are not too keen on this idea of distributing healthcare resources according to merit. And they actually state an argument about it on page 17. You can tell this because they begin a sentence with the phrase, "the point we wish to make." So whenever someone says something like that, "the point we wish to make," you should take note and underline it, right? Because that is the argument that the authors are trying to make. So the point we wish to make here is that merit criteria for resource allocation are often used unconsciously or appear disguised as other reasons. So they're not too keen on distribution according to merit, but they think that it shows up a lot, that people are actually using it a lot in reality without being aware of it. So the point we wish to make here is that the merit criteria for resource allocation are often used unconsciously or appear disguised as other resources, as other reasons. Such a situation is undesirable. If we are to use social worth criteria, the debate about their acceptability needs to occur in an open and constructive manner. So they are saying, if we're going to do this thing, we need to debate it in an open manner. Okay? So that's distribution according to merit, according to some idea of character or compliance or social role, past, present, or future. Okay, the last one that they talk about, and the last thing we're going to address in this lecture, is the distribution of healthcare resources according to rights. And this is one of the places where the audience, the intended audience of this chapter comes in, right? So our authors say that they don't bother talking about rights too much, rights to healthcare in the UK, because it's enshrined in law. Here in the United States, the right to healthcare is not enshrined in law. So they say this is not necessarily the case in other countries, notably the United States of America, in which the debate about resource allocation tends to focus mainly on rights. So what they're saying is that the discussion of the right to healthcare is more important for us in the US because it is not guaranteed by law in the same way that it is in a socialist medical organization. You don't have to have stakes in socialized medicine or not socialized medicine to see that. So the right to healthcare is the idea, it's just what it sounds like. It's the idea that you, anyone, as an individual in a society, has the right, has the privilege, the ability to receive whatever healthcare they need, in theory, right? So in the UK, healthcare is a right guaranteed under law, just like freedom of speech is a right guaranteed under law in the United States. So you, as a citizen of the United States, have the right to say whatever you want. That is the rule of freedom of speech, and it is not the rule in other countries, including the UK, right? We have a right to the freedom of speech. We have lots of other rights here too, right? We have the right to bear arms, also not a right that you have in the UK, but we don't have the right to healthcare. We do not have the right to universal healthcare. But in the sense that these are rights that are determined by law, they are contractual rights. They belong to the social contract. That is the big, big contract upon which government is based. This is an idea that comes from Rousseau. You guys don't need to worry too much about the history of this idea, but basically the idea is that individuals make a contractual agreement with their government that they will be citizens, and in return they will be guaranteed certain rights, that the government will protect their rights. And that's one of the sort of basic tenets of the social contract. Okay, so in some places this social contract includes the right to healthcare. Our authors distinguish between two different kinds of rights that you might have. So there are innate rights, that is the idea that you are born with certain rights. And there are contractual rights, that is the idea that there are things that are owed to you because you formed a contract, right? So if the social contract is the sort of like big, big, big grand version of contractual rights that seems so big that it's almost like an innate right, we can think of ordinary contracts as an example, as things that occur in a situation where you have the right to a service because you are paying for it, right? So a very simple example of contractual rights would be, I go to the grocery store and I buy some milk, okay? I have the right to pick up the milk and take it out of the store and take it home and drink it because I have given some money to the cashier, who in turn gives it to the store owners and the whole system of the store, right? So that is a contractual right. I have made a contract, a very, very small contract, with this store that if I give them $3.50, I will in return get a half gallon of milk, okay? And we can think about the right to healthcare in the United States as something that functions as a contractual right in this sense, right? So as someone who is paying for health insurance, you have the right to certain services, medical care, provided by certain doctors that are according to your insurance plan, right? So because you are paying for this, you should get, because I am paying for X, I should be able to get X. That's simple, right? Our authors here give us an example of a patient bill of rights. And this is sort of an example of contractual rights that a patient and their provider might share. The rights that a healthcare practice might guarantee that they will provide to their patients by virtue of the fact that these patients are patients in their practice, that they are paying them for these services. So it's an example of contractual rights. And the one thing I want you guys to note is it includes confidentiality, which is the topic that we will be turning to the week after next, after our exam. Okay? So that's it for this week. So remember those 4 key terms: the distribution of healthcare resources according to rights, according to merit, according to capacity to benefit, and according to need. Those are the 4 things that make up the idea of distributive justice. Okay? So that's it for this week. Thank you guys for listening. I know this was a long one. And I look forward to hearing from you on Thursday. Okay? Take care.